everyone. I'm Jasmine with the Community Engagement Team at DDS, and a few things to note before we begin. If we could go to the next slide, please. We're offering ASL interpretation for today's meeting. The interpreters have been spotlighted, so their video will always be displayed, and closed captioning is active. This meeting is being recorded and will be made available on the department's YouTube channel. Materials were emailed this morning, but we're also posting them in the chat for you. You may send written comments via email to autism@dds.ca.gov. Next slide, please. Your controls for today's meeting are available in the Zoom toolbar at the bottom of your screen. Chat is open throughout the webinar. Please use it to stay engaged. We'll have a Q&A session during the last 10 minutes of the webinar, and you may submit questions using the Q&A button. And you may also use the thumbs up to upvote a question. Feel free to use the raise hand button during the Q&A session towards the end of the webinar to come off mute and ask your question. Lastly, please take a minute to complete the survey that will appear as you leave this webinar. Your feedback is important. Thank you, and now over to Dr. Lauren Libero to introduce today's webinar topic. Thank you.
Good afternoon, everyone. My name is Lauren Libero, and I'm the Autism Program Specialist at the California Department of Developmental Services. I oversee our Autism Services branch, and I am so excited to have all of you here with us this afternoon. I see many of you sounding off in the chat where you're from, and it is really wonderful to see people from all over the state to hear about this topic. So I am delighted to introduce to you our distinguished speaker, Dr. Jessica Schwartzman. Dr. Schwartzman is the director of the Training and Research to Empower Neurodiversity Lab at the Children's Hospital, Los Angeles, and clinical psychologist for autism and neurodevelopmental services in the Division of Developmental-Behavioral Pediatrics. She also holds professorships at the USC Keck School of Medicine and Vanderbilt University Medical Center. Her clinical research career is focused on the diagnosis and treatment of depressive and anxiety disorders and risk management, and she holds special expertise in these topics at their intersection with neurodivergent children, adolescents, and adults. So please join me in welcoming such an esteemed speaker, Dr. Schwartzman.
Thank you, Dr. Libero, for having me. And thank you to everybody. Shout out all across California. I was born and raised in this state, and I love it. I did spend a 4-year stint in Nashville, which was wild, and I'm happy to be back in LA. So thanks for everybody attending. And I think I'm particularly excited about this webinar because it feels like an opportunity to converse with peers, folks who, like myself and many of my colleagues, are on the front lines trying to tackle this really tricky issue of suicide risk in folks that have autism and other intellectual and developmental disabilities. So I appreciate a chance to share with you all. I'll go over a few disclosures. I don't have any financial conflicts of interest to disclose. My lab is supported by several federal and international agencies. In terms of my professional training, it certainly biases the lens that I bring to my work, so it's important to disclose those. I've had training at UCLA, Stanford, and Vanderbilt. From a personal lens, I do also think my identities can influence the work that I do and the way that I treat patients. I am an older sibling and a caretaker of an autistic young adult who has intellectual disability. So that has certainly shaped the past multiple decades of my life. And I think has also given me, the opportunity to understand both sides of what this can be like. I will also note that the nature of this presentation can be extremely sensitive and challenging. And so I just want to invite all of our attendees to engage with this talk in a way that makes you feel comfortable and safe. So you can step away, you can mute me, anything that you need to regulate and, again, feel safe during the presentation. I always welcome and encourage. I also believe firmly that science is a team sport, and I would not be able to give this talk or share so much of what we do without this incredible team. I have lab members at Children's Hospital LA, as well as folks that I worked with at Vanderbilt. Certainly, the work is funded by great agencies that I think care much about this topic as much as we do. But I also really want to highlight my autistic collaborators. You'll see them listed in the top right corner. These are folks who have lived experience of both an autism identity and a mental health crisis, either currently or in the past. And these are folks that are really engaged in community-based participatory research that we do to understand things like suicide risk and how can we improve those interventions. So I want to recognize a significant amount of work that they have contributed to what you'll hear about today. So in terms of what we're going to cover, I'm sure you can imagine that covering suicide risk in neurodivergent folks is incredibly challenging in 1 hour, and I recognize that. So this is really meant to be an overview that hopefully leaves folks with a sense of evidence-based practices. So we'll talk about the existing science on suicide risk in this community. I'll go over a few recommendations that we have in terms of best practices for suicide assessment and screening. And then I'll also go over some recommendations for when you go to use a safety planning intervention with autistic or other neurodivergent folks, how you can adapt it to be more neurodiversity affirming. So broadly speaking, it's no surprise that we are in an active youth and adult mental health crisis in the US, and we have been for multiple years, and has certainly been exacerbated by the COVID-19 pandemic and the continued fallout of that. And so I think it's important to talk about the national landscape that we are in, where, for example, suicide is now the second leading cause of death for young people in this country. And I think that really speaks to the level of crisis that we're in as a country when it comes to mental health. And I think that broader US context is really important to keep in mind when we think about this question of what do we know about suicide risk specifically in people with IDD? And that's a lot of what we're going to talk about today. So I pulled this from a very large and well-known federal agency that I think captures what many organizations and agencies reflect, which is that we have very limited data on suicide and mental health outcomes among people with disabilities. And I think as a practitioner, as a researcher, even as a sibling, I feel this very immensely. And I think there's some key reasons that lead up to that and some important things for us to consider. Fortunately, there has been some more recent research that's looked into this wide gap, and we know that people with IDD are 2 to 3 times more likely to experience depression, 6 to 8 times more likely to experience anxiety or even be diagnosed with an anxiety disorder compared to the general population. We also know that this population is far more likely to experience victimization in any form and often in multiple and repeated forms, well above those that are reported in the general population. We also unfortunately know that people with IDD are 3 to 4 times more likely to attempt suicide than those in the general population. And unfortunately, suicide has become a leading cause of death specifically for autistic people. What we all know, particularly our practitioners in the audience, is that people with IDD are far more likely to utilize these higher level care units, whether it be presenting to an emergency department, being admitted to an inpatient unit. And not only are they more likely to present to those, they're more likely to remain in those costly and really challenging environments and be repeat visitors, meaning having to come back multiple times. And so I think what really stands out to me as I think about we're learning what we know about mental health in this space is it's extremely costly. Financially, emotionally, mentally, physically, there are substantial costs to the fact that this is the reality that people with IDD are experiencing. It's costly for the person. It's certainly costly for the family, for the community, and our broader systems level. This is not sustainable when we think about best ways to serve folks who are in crisis. I'm going to talk a little bit more around, again, this topic of suicide risk in the IDD and autism community. So we know from research in my lab and others as well, both for youth and adults, that those in the community are far more likely to think about and go on to attempt suicide than the general population. I think this is really critical to talk about because often the narrative around autism or IDD does not include mental health or recognize that this population is particularly vulnerable to these experiences. And what I want to emphasize is that people with IDD of all ages are at risk for suicide. And certainly we see different heightened vulnerability across developmental periods, but we do see elevated suicide risk compared to the general population regardless of age. Some of our work shows that suicidal thoughts can come or emerge for folks as young as 7, and they can persist over the lifetime. And so thinking about ways to best serve youth at that end of the developmental scale is really important. Some of my work shows that overdosing is actually the most reported method of suicide attempt among people in the IDD community, particularly among adults. And I think that this is alarming because what we know from people with IDD is they're far more likely to be prescribed psychiatric medications and take them on a regular basis. So here they have a much higher access to a potential means of suicide that they often report is the one that is most common when they're thinking about or contemplating suicide. Some other methods that we hear a lot in our work across youth and adults are strangulation, stabbing, and particularly for kids. There's a high number of youth who think about jumping out of a car at some point while driving with their family. The other thing that I want to point out within the very large community of people with IDD is that suicide risk cuts across sexes, genders, racial and ethnic identities, socioeconomic status, and regions, both urban and rural, but obviously to very differential degrees. And so it's really important when we're working with people as providers to think about all of the identities that they hold in addition to their IDD identity and how that might impact their risk for suicide. So I probably don't have to tell this group, but there's not a singular reason or factor why somebody might go on to think about or attempt suicide. And rather, it tends to be this multitude of co-occurring risks that can happen to individuals. And I'll share some here that tend to be more common among people with IDD that we know from research in the general population are really strong risk factors. So things like family history, impulsivity, substance use, social isolation, unmet basic needs, disrupted or lack of relationships, both platonic and romantic, chronic illness, and other means, right? So we think about kind of these multitude of co-occurring risks. And I think what's alarming is that people with IDD are more likely to not only experience a greater number of these at once, but the challenges that they face in these spaces tend to be more intense and problematic for them than their peers who might not have an intellectual or developmental disability. At the same time, many folks, including my lab, were really interested in what might protect against suicide. Are there factors or experiences that might buffer against this? And similar to risk factors, there's not a single thing, a single kind of factor that would prevent someone from experiencing suicidal thoughts. And rather, it's a collection of multiple protective factors occurring at once, often feeding off of each other, that can help prevent or buffer against this experience of suicidality. So being socially included, receiving consistent and stable mental health care, access to basic health care as well, coping skills, reasons for living, school services and interventions, even like IEPs or 504 plans. So often when I'm talking about suicide prevention, whether it be with families or providers or folks around, is really thinking about suicide prevention is not simply a mental health professional delivering a particular treatment or intervention, but it's also all of the systems that a person is in, that they're getting their basic needs met, that they have stable housing, consistent employment if they're an adult, access to healthcare. All of these systemic opportunities or services that we have are actually suicide prevention strategies that we often don't think about when we're working with someone right in front of us. I'll talk a little bit about common misconceptions regarding suicide. And I suspect they might not be as common among this group, but I think they're important to go over because they do apply to people with IDD, even if there might be some hesitancy about how to approach this topic with this particular community. So one common misconception is the idea that asking somebody about suicide will increase the likelihood that they actually have those thoughts or go on to attempt suicide. And very similar to what we see in the general population is that asking about suicide in people with IDD does not increase the likelihood that they will think about or attempt suicide. And in fact, asking about suicidal thoughts, asking frequently and over time increases safety. The other misconception is, I think, long held that people with IDD don't experience suicidal thoughts or behaviors, don't have mental health distress, and it might only affect people in the general population. But we see that suicide risk is actually universal across people with various IDD disabilities, but we see that suicide risk might be particularly high among people with an identity of autism. The other misconception, like I kind of hinted to this on my last slide, is this idea that suicide prevention lives only within mental health providers, that we are the only people that can really prevent suicide or help somebody come out of a crisis period. And actually, we see that people who are getting interventions at all levels, right? Whether it's a family support group, whether it's a particular school intervention like an IEP or a 504, or having access, again, to regional centers, state-funded program, national policies, healthcare, all of these really critical things that help meet someone's basic needs are actually pretty substantial strategies that are really effective in preventing suicide. So thinking again, not only about the client or patient sitting in front of us and how are we going to work through safety in the moment, but considering all these broader areas that are certainly going to impact whether they're experiencing a crisis or not. So I often get asked this, what do we do when it comes to assessing or screening for suicide in people with IDD? One of the things that I'll talk a little bit about are some common challenges that providers will often encounter when trying to assess for suicide in this population. One of the first most common ones that we see is called diagnostic overshadowing, which is briefly this idea that symptoms of two or more mental health disorders might overlap and make it challenging to either see them separately or realize that multiple ones are occurring within the same person. So, for example, often what we see symptoms of depression, if we think about kind of blunted affect, if we think about minimal engagement or isolation from others, that certainly can be symptoms of depression, but it can also be experiences of people with IDD. They may simply have a flatter facial affect. They may simply enjoy more time alone than someone who is not having an IDD identity. And so it's really challenging sometimes to figure out, is this part of the person's IDD, or are we also looking at a co-occurring depression diagnosis? Anxiety operates very similarly, right? Sometimes in anxiety, people will have ritualized behaviors that help decrease their anxiety in the moment, and then, as we know, can be really hard to shake over time. It's also possible that those rituals are part of their IDD identity, particularly among folks with autism, so it can be challenging to figure out, is this person experiencing this behavior distress related to part of their neurotype, or is this also anxiety and something that we need to act on? And suicide risk operates very similarly. It can sometimes be very challenging to detect in people with IDD because we're unsure whether the experience is attributed to their neurotype or whether it might suggest an actual suicide warning sign. Another challenge that we face, I'm sure many of you on this webinar will recognize, is that it's really challenging for people with IDD, both youth and adults, to first identify that they might be in a crisis or experiencing suicidal thoughts. So that recognition in themselves might be challenging or done in a different way that's harder for other people to see. The other kind of second companion to that is that if they are able to identify that they might be in a suicidal crisis, it's incredibly challenging for them to communicate this crisis and seek help from people like caregivers or providers. And we attribute that sometimes to social communication differences that are characteristic of people with certain IDD, but it's also attributed to alexithymia, which we know can be present in up to 80% of people with autism, for example. And so we have to, as providers, recognize that if we have a patient or a client who is really struggling to identify their warning signs of crisis or tell us in sessions that they're in crisis, it's likely not that they're, problematic or they're trying to disengage or not help themselves. It's more likely due to things like alexithymia or these social communication differences. Another one that we've published on quite a bit is this idea that there are pretty significant differences between youth with IDD and their parents regarding suicide risk and anxiety and depression. So I'll clarify a little bit. As we know with general population, teenagers and youth, there's always going to be differences between what the youth thinks is occurring and what the parent sees. And there's a natural divide. However, some of our work shows that the divide is even more substantial when we look at youth with IDD who might be in crisis and their caregivers. So even, when we are working with youth and adults, sometimes collateral information is really critical. But what can make it more challenging in our world is if that collateral is so far off from the individual's experience, it makes it really hard to know what is the crisis, what is the intensity of it, and how should we try to address it. So there are many other challenges to assessing for suicide risk, which I fully recognize, but I think these are three of the most common and significant ones that we're up against as providers. From a practical standpoint, I get the question a lot of what tools should I use to screen for or assess for suicide in people with IDD? And the challenge is all of the available suicide assessments that we have were developed specifically for neurotypical people, normed and tested on the general population. And so they might work really well for the general population, but we don't really know to what extent do they work, if at all, for people with IDD. And, one of the things that we think a lot about is in the general population here at my hospital and in plenty of hospitals, we use a lot of interviews to determine the presence or the severity of a suicidal crisis, right? We might use the Columbia Suicide Severity Rating Scale or some version of that interview. The challenge with interviews, though, if we think about it, is they're a social interaction by nature. I ask a question, I expect the other person to respond. Once they respond, then I have a follow-up question. It becomes this social exchange. Well, from what we know from people with IDD, they're very clear that social interactions can be highly stressful or confusing for some, if not most, people with IDD. And so if we as providers rely on a socially based interview to assess for crisis, it's likely that it will work for some clients, for sure, but it's unlikely that it will capture everybody at risk. So we think a lot about what might be missing from interviews that we can capture in another way. The other challenge, so let's say we don't do an interview and we give a youth or an adult or their caregiver a survey, whether it's printed out or online or something like that. The challenge is, again, we're taking tools that were developed for the general population and hoping that they work for people with IDD. And there's been some research that suggests there's some challenges in using surveys for youth with IDD that they might not be as valid, again, because they weren't specifically designed for this population. The last thing that can be a little challenging when it comes to trying to assess and use tools for identifying suicide risk is the fact that suicide warning signs, distress, emotion recognition, and regulation all present very differently in people with IDD. So for those of you on this webinar, like myself, I was not trained in graduate school, internship, postdoc, anywhere in how to recognize different signs of crisis in people who aren't kind of the standard general population. So it makes it really challenging to know what should I be looking out for that might suggest a patient or a client is in crisis. So it's been a little bleak so far, which I recognize. I am encouraged, though, to say that there are some teams working on suicide assessments and screeners that are designed specifically for and with people with IDD. But as you probably know, unfortunately, in research, things can take years from first development in the lab to becoming publicly available. And so I think it will take a few more years for those tools to become available, but I'm excited for all of the work that's going into those. So as we wait, right, many years, hopefully not too many, for these tools to come out, we're stuck with, well, what should we do in the meantime? How should we, as best we can, reliably assess for suicide in people with IDD? And a lot of our work suggests the efficacy of a combined approach. So what we typically recommend is combining an interview with some form of a self-report. That could be, again, a printed survey. It could be done online. It could be done by texting. Having flexibility with how we get this information is okay. But it's critical to have, again, that clinician or practitioner-based interview along with some self-report type instrument. And so when we think about the interviews, again, we know we want to use both with people with IDD, including youth and adults, but we know that interviews can be challenging because they're social in nature. So we have some recommendations for how to adapt interviews. One of the first things to consider is different communication modalities for the interviews. They don't necessarily have to be two people sitting in front of each other, staring at each other, asking questions and responding. Rather, we can do interviews by texting. I've had patients write notes. I've had patients point to their answers to my questions. I've had patients prefer to do video chat because that feels more comfortable for them. So I think having flexibility with how we do interviews is very critical. The other thing that I would highly recommend is allowing additional time to complete the interview. Because as I mentioned, alexithymia is very common. What I often hear is patients will say, I don't know what I'm feeling. I don't know if I'm in crisis. Or they may take a longer time to respond to my questions. They may need more concrete additional follow-up questions to respond. So I think having some flexibility with how these interviews are done, I think are going to be able to access patients in a more meaningful way. So the two that I typically recommend, again, this is just from what we know to date. Again, we're doing a lot more work in my lab right now to, again, figure out what tools should we use in the meantime. But we tend to encourage the Columbia Suicide Severity Rating Scale. Tends to be very concrete and direct in its questions, which I think is more accessible for people with IDD. Now, even with the Columbia, we do have some adaptations that we add, we use, as I mentioned, that can make it more accessible for people. And then self-report surveys. So we use the PHQ-9, can work pretty well both in capturing depression and that suicidal ideation. It's been validated for multiple communities of people with IDD. We also use the Suicidal Ideation Questionnaire Junior, and that can be really helpful in drilling down specifically the types of suicidal thoughts and the intensity of them if children are experiencing that. Okay, so I'm going to shift out of assessment. So once we've identified somebody at risk, then we have to think about how are we going to provide an intervention? How are we going to support this person as they're in crisis? It's probably not surprising to anybody on this webinar that interventions are not a one-size-fits-all. And I'm not here to say that anything I'm going to present is going to work for everyone. But the goal is that this can hopefully capture the majority of folks as we continue to research what are the additional things we need to do for people who don't benefit from these more widely available interventions. Also, in thinking about suicide prevention, I'm often working with other providers. This might be a psychiatrist, a social worker, a nurse practitioner. Other people who have different disciplines and trainings can provide really great services that can help support someone in crisis. So again, it might be a therapeutic approach. It might be a psychopharmacological appointment. It's hard to say, but again, having that team of people that I can collaborate with and work on is very helpful. The goal, too, that I think is really important for people with IDD is we want to avoid patronizing or infantilizing this population. And so having the individual at the center of all of our safety planning conversations and strategies is really key. And also recognizing that caregivers or collaterals, perhaps a spouse or a sibling or a parent or whatever, may be helpful when we're thinking about planning for suicide prevention, but not always. And so having that discretion about whether or not this collateral is going to be beneficial or detrimental to our goal of keeping the person safe. So I'm going to talk briefly about safety planning intervention in its original design. So this is a really great intervention that is done by folks. It's at the Columbia Lighthouse Project. So I included a link to their website. They have fantastic online resources, trainings, great materials that are readily available that is it gives an overview and training in safety planning intervention. Again, I will reiterate, this intervention at its core was designed for the general population. So at this slide, we've not adapted it yet, but I think it's important to learn the basic components of safety planning intervention because it's going to be much of what you'll see in a minute when we think about adapting an intervention for people with IDD. So the goal of safety planning intervention is to develop a plan with the person and their collaterals, if applicable, to manage suicidal crisis. Again, it tends to be episodic. So the goal is to help somebody stay safe during that particular period. And then eventually help them learn strategies to decrease suicidal thoughts, urges. What's great about safety planning intervention, again, in this original form for the general population, is it allows the provider to simultaneously assess for suicide, whether it's present, the intensity of it, things like that. And it also engages the client in an intervention at the same time, which is great. I also really like this intervention because it's brief. It can be done in 30 minutes. It can be done in 60, depending how much kind of back and forth and collaboration needs to go on. And it can be delivered by a variety of healthcare professionals. So we've seen nurses, social workers, I've seen medical assistants, physicians learn how to do this intervention. And I think that that's really important because people with IDD are in many spaces and might need help across those different contexts. The reason that we think that generic safety planning intervention might be an optimal one to adapt for people with IDD is several reasons. One, it is the most well-known and widely distributed suicide prevention intervention, at least in the US. And so many providers are far more likely to be used to this style of an intervention than if we were to create a completely brand new one. And again, if we want to think about the uptake, that's important. The other thing is safety planning intervention is very concrete and formulaic. It reviews steps that people can take when they're in a crisis. If a particular step doesn't work, what's their backup step, the backup step after that, right? And it's very clear and written out. And the key is that it's brief and collaborative. And so it's something that we think, based on what we know about people with IDD, might be more acceptable to them. However, like all interventions and all assessments, we can't assume that something that is readily available and designed for the general population is immediately going to work for people with IDD. The reason that that is we know that people with IDD have unique sensory experiences. They have different styles of thinking. They may have different emotion recognition and regulation challenges. For example, alexithymia that I talked about is really common. Behavioral differences are key and common among people with IDD. And so we can't immediately assume that a generic safety planning intervention is going to work for a population that clearly has a different presentation. So what we have done, and we're actively running a clinical trial right now on this intervention, is taken the original safety planning intervention and provided some suggested adaptations so that the intervention will work more fluidly and effectively for people with IDD. What I will pause and say when I share these suggestions is that these were developed with my autistic collaborators, who I showed, I think, on one of my early slides. And so we, over a series of many meetings and emails and back and forth, have thought sensitively about how to recommend particular adaptations to this intervention. But because we're actively testing it right now, it's possible there may be more to come, but these were the ones that we felt we're confident in thinking of how to adapt it for this population. So one of the first steps of safety planning intervention is to help the individual identify their own warning signs that they might be in crisis. Now, again, it can be really challenging for people with IDD to identify and communicate their distress. And so what we have recommended is when we're helping somebody identify their warning signs is providing concrete explanations of physiological signals or behaviors that they might use to help identify emotions. So for example, when I'm working with patients, I will often say, if your stomach hurts and your heart starts beating, what might those be telling you? And I think that, again, if we approach this in a way where we're helping somebody identify that the body is an important source of information and that particular body signals can convey that key information, simply by paying attention to our body, that might give us helpful information if we're at risk or not. Another thing that we do is we talk a lot about behaviors. So we'll, note that, for example, someone in crisis might pace back and forth a lot. They might engage in stimming behaviors. They might even engage in self-harm behaviors more than usual. They may isolate themselves from others. They may feel more impulsive or have really significant energy. And so we're working to kind of point out these behaviors that they may be engaging in and noting that the behaviors might be a change from their baseline. The behaviors might be a new behavior, or they might be a behavior that's happening more frequently and more intensely. And that might be clues that someone's in a period of crisis, and those might be those warning signs. Other things that we think a lot about, but they're not necessarily autism specific. I would say that they're more neurodivergent people specific, is thinking about sensory overload. We know that people who are neurodivergent may experience the sensory world in a far more profound way than those who aren't neurodivergent. Sometimes it can be lights, sounds, textures. And the challenge is that we know from a lot of our work that people who do experience that sensory overload or overwhelm, that can actively trigger a suicidal spiral. And so we want to think about working with them to identify whether sensory overload is a warning sign for them that they might be in crisis. The other one that we work a lot on is social burnout. So we know that far more mental, physical, emotional effort is exerted by neurodivergent people in social interactions than people in the general population. And that exertion is going to have a price, right? It usually causes fatigue or what we consider burnout. And so often we're bringing in this discussion of whether the person is experiencing social burnout. And if they are, that might be a warning sign that they're approaching or are in a crisis. So once we've worked with somebody on helping them to identify what are their specific warning signs that they might be experiencing a crisis, we then shift to the first level of the intervention, which is thinking about coping skills. What are things that they can do on their own to help themselves regulate as they're experiencing these warning signs or experiencing distress? So there are many coping skills that work great for people with IDD as well as people in the general population. This might be breathing techniques. This might be, different distractions, might be listening to music, playing video games. All of those are great if they also work for the person with IDD. And again, that's where having a conversation can be really helpful. But we also recommend additional ones to think about or suggest when working with someone with IDD. The first one that we often recommend in terms of coping is time alone in a quiet, sensory-friendly environment. Often sometimes parents or other people will be hesitant about alone time and feel that that might be contributing to the isolation. And we always validate that worry because that's very genuine, of course. But we know that this alone sensory kind of neutral experience can be very regulating for people with IDD and very beneficial. So having access to this alone time is really critical as a coping skill that we often want to introduce if the person isn't already using that as a coping skill. The other thing that we think a lot about is encouraging the person to engage in their particular interest. So it's common across people with IDD that they might have narrowed specific interests that bring them a lot of regulation, enjoyment, and we want to encourage those as a coping skill. That might be anime, video games, and things like that. Now, obviously, everybody is different. My own brother, for example, has an interest in weapons. So certainly, we would not want to encourage, a child or an adult with an interest in a particular activity or hobby that might be dangerous. In fact, that might be one that we would want to talk about, taking a pause from that while we're trying to get through our suicidal crisis. So again, having discernment, and that's where collaterals can be helpful about whether or not a particular interest is a good idea as a coping skill or not. The next level of intervention, if coping skills on our own don't work for managing our crisis, we can think about social support for distraction. So this might look like going to a nearby park or a shopping mall, some place where people can get that social distraction without having to disclose that they're in a crisis. Now, the challenge with people with IDD is some really do enjoy social experiences and going to the mall, and so we would want to encourage that. Others might feel taxed, and that might exacerbate the crisis. And so really considering as providers whether social support and distraction will help or not. What I often recommend too is thinking about engagement in online communities. We see that kind of reduced burden of those in-person interactions through online interactions can be more regulating and less stressful. So thinking about if there are ways for people to get that social support for distraction, but maybe that's done digitally. Sorry, let me go back. I was also going to say, in addition to places to go for distraction, we think a lot about people that can help someone distract themselves from those thoughts. And then, as I mentioned, you may have a client that has those key people in their life. It might be a cousin or a guidance counselor or a favorite teacher or a best friend. And you may have clients who don't experience regulation and safety by being around other people. And so learning from them what their experiences are like is really key as thinking about whether or not we want to encourage this particular strategy or not when thinking about staying safe. Then what's typically common if these intervention levels are not working for an individual, we give an overview and talk about the role of professional support. So this might be getting in touch with their psychiatrist, contacting their therapist, that might be contacting you as the provider, right? And so we make sure that the individual has the name and the phone number or any contact information they need to access that support quickly. But what we often encourage when we think specifically about people with IDD is role play exercises, because we know that asking for help or communicating distress is a common challenge in this population. And what can help is practicing. So I have literally gotten my phone out and practiced calling 988, for example, with patients, or I've practiced with patients typing a text to say that they need to talk to their school counselor or their therapist. So again, thinking of ways to make that communication less stressful for them, we find can be really helpful through role plays. The other thing that we spend a lot of time on is literally writing out numeric steps for how to access 24/7 crisis supports. So for 988, we'll just using that one, right? Grabbing your phone, either texting or phone call, and literally writing out how to do that, and then writing out what will happen. There is going to be some wait time. Wait time does not mean that the organization doesn't care about you. Wait time does not mean that your crisis is not important. It simply recognizes the volume of callers that people need to get to, and you will get addressed, right? So really laying out as best we can what will happen as people try to access these professional supports can not only help the individual prepare for that interaction, but also not have as significant anxiety when they face these things that might feel uncomfortable without that priming. The other thing we think a lot about is how to keep the environment safe. So very similar to what we would do in the general population, we think about removing harmful objects from the general environment. One of the things that we also encourage is to think about the particular passion interest that the individual might have and whether or not that could pose additional danger or risks to the individual. So again, somebody with an interest in weapons, we would need to put those away, right? Or somebody with, an interest in horror movies, those may or may not exacerbate someone's crisis. And so thinking about whether those need to be put away from the environment to hopefully help prevent an escalation of a crisis. So a few things that I wanted to share. There are several groups that are actively working on ways to develop crisis supports and tools both for and with autistic and other neurodivergent people. So I've included 3 here. The first one is there's an autism and suicide prevention work group. Their link is there. And they've put together a ton of resources for youth and adults on accessing supports to stay safe that are really effective and helpful and free and publicly available. The other thing is American Foundation for Suicide Prevention does have a webpage that speaks to suicide prevention techniques and tools for people with autism or other IDD that can be very helpful. And then I also recommend there is a great nonprofit organization run for and with autistic folks that is called the Autistic Girls Network. And unlike the name, they have options available for people of all genders. And their resources are not only available related to suicide prevention, but talk about all those other areas that are really important in supporting someone with IDD. For example, how to navigate the school system, how to find employment services, housing, and things like that. So I highly recommend these resources as you're thinking of ways to learn more for yourself as providers, but also to support the people that we serve. So again, really challenging to cover such a dense topic in a short period of time, but I hope some takeaways are clear from what I've discussed today. The first is that suicide is really a substantial problem that is facing the IDD community. It has only become, I think, on everybody's radar in the last 5 to 10 years, but it has been a chronic problem, and I think will continue to as we face many challenges. We know that suicide in this population, suicidal thoughts and behaviors, I should say, can typically emerge in childhood, particularly adolescence, far more than the general population, and is more likely to persist over the lifespan for this population compared to the general one. The second thing that I would recommend is that public health and mental health professionals do play a substantial role when it comes to suicide prevention efforts, not only in screening for suicide risk and safety planning, but they can also play key coordination roles in accessing school services, employment, regional center care, healthcare. There's lots of ways that we can support people outside of our clinical office or interaction. And when we think about what we know right now for suicide assessment, the evidence suggests that combined approach of an interview and a self-report. And for safety planning, we do provide several suggestions for how to adapt a really reliable intervention to meet the needs of people with IDD. So as we kind of conclude, and we'll eventually shift into Q&A, I think these are questions that I posed for the audience, but to be honest, I still grapple with them all the time myself as a psychologist, is how do I foresee, or how do you foresee taking an active role in suicide prevention efforts, whether it's with your individual clients or your organization or clinic more broadly? And kind of based on what we've talked about so far, is there anything about your own practices or organization that you would want to change, perhaps to be more neurodiversity affirming or more inclusive for people with IDD? And what would that actually look like? What training would be needed? What tools would you need? And things like that. And if there's anything that you can take from today that will hopefully help directly impact work that you do today and moving forward. These are my references, and I will go ahead and wrap up, and I believe we will shift to Q&A.